Today we are going to hear from Dr. Gowrisankar. Over to Gowrisankar.
Good morning, all. I thank the organizers for the opportunity given to me, and my humble greetings to Professor of Rural Pediatrics, Dr. Murugesan. This is what I can call him as. We'll go to the topic straight away. Tuberculosis, overdiagnosed or underdiagnosed. See, in 2020, 1.1 million children had TB globally, and among these 0.192 million, they died. Majority of them were under 5 years of age. The poor outcomes are mainly due to non-specific nature of the symptoms and signs in TB, the paucibacillary nature, and challenges in getting a good respiratory sample. Much more than that, what is really troubling is more than 90% encountered delay in receiving treatment, either never received the treatment or they are not even diagnosed with TB. In practice, most of the time, the diagnosis and confirmation is often limited to secondary and tertiary facilities. At the primary level, it may not be detected early. If you're going to give pressure, to the primary physician to increase the case detection, you're going to lead to overdiagnosis, which can lead on to unnecessary treatment and high cost burden, not only to the parents, but also to the health system as such. This is a child, 13 years, who had presumptive symptoms of TB. This is the X-ray, which shows a spot, probably like something like a fluffy lesion in the left upper lobe. Clinical diagnosis, tuberculosis, CBNAAT was negative. Advised anti-tuberculosis treatment, but they came for second opinion. So what I did, need to do a CBNAAT because the X-ray was suggestive of that, but CBNAAT was negative. So started on antibiotic for 14 days, a repeat X-ray. It shows good clearance, but still this age, always be careful. Follow them up. Yes, the X-ray has cleared, but follow them up in 1 month's time. There is good weight gain, and the repeat X-ray after 1 month also is normal. So if we had started ATT, it would have been an overdiagnosis. This child who had got lymphadenopathy in the left side and child received antibiotics, did not settle. So under general anesthesia, the pus was taken out. There was a query caseous nature of the pus, but the node excised. What happened? CBNAAT was negative. The histopathology suppurating granulomatous inflammation, TB, to be considered. So what to do? Second opinion and a good history. Everything started 2 weeks post tonsuring and ear piercing. So after that, the child developed the lymphadenitis, and after a good course of antibiotics, it settled. So Manto was negative, parental screening was negative, the child was gaining weight, so it is not TB. So overdiagnosis is possible, and WHO adopted the NTB strategy in 2015. But normally, what we do is, we always go by the symptoms, tuberculin skin test, then imaging, then microbiological diagnosis along with a good history to make a diagnosis of TB. But underdiagnosis is often the rule. The children get diagnosed and treated only through referral system. This is the paper which Dr. Winsley Rose has published from Christian Medical College way back in 2018 December. And history, we don't have many pitfalls, but we do have pitfalls in clinical exam, imaging, tuberculin skin test, IGRAs, CBNAAT, and diagnostic algorithm. We'll go one by one. Common encountered is lymph node TB, and this is the common extrapulmonary tuberculosis. Clinical diagnosis, we always make, looking at the swelling, we make a diagnosis of TB lymphadenitis. But this paper in 2009 had compared fine needle aspiration and excision biopsy against the gold standard of culture, found out that lymph node TB is overdiagnosed in at least 15% of the population. And coming to imaging, X-ray, mediastinal lymphadenopathy, this is the radiological hallmark of primary TB. It is difficult to make out in a chest X-ray unless otherwise it's so big like this. And interpreting pediatric chest X-ray, there is significant inter-observer variation. Also, pediatric X-ray doesn't have cavitations and something like clear radiological signs of TB, just like what we have in adults, so difficult to interpret. Very rarely, you can have notes like this. If you don't look at it in an X-ray lobby, you have a tendency to miss out like paratracheal lymphadenitis on both sides. Imaging is important not only for diagnosis, but also for follow-up and response assessment. Many times we resort to CT. CT always will show small sub-centimeter nodes, especially with good CT machines. But don't interpret this as tuberculosis. Whenever you think lymphadenopathy is probably due to TB, you need to know that only active disease, active lymph node disease will have enlargement, central necrosis with rim enhancement, obscured perinodal fat, and coalescence and calcification. These are the signs of lymph node TB when you do a CT chest. Coming to tuberculin skin test, measuring induration, even experienced observer, the induration measurement varies by 15%. It is highly variable in inexperienced personnel and untrained lab people. But we also have to know that higher rate of tuberculin skin test positivity in BCG vaccinated children, and if they have exposure to TB, and falsely it can be negative in HIV infected and malnourished population. Even the recent paper, we know that a lot of malnourishment is there in children. In most places, TST is not available. Government is planning to introduce the Copenhagen TB, CTB, which is going to replace the Manto test, but because of the COVID, it has not come into practice. Now, Government of India had slowly changed from, previously they said IGRAs should not be used, but now they say you can use TB skin test if it is available. If it is not available, you can use IGRA for detection of TB infection. This report came in July 2021. Now coming to IGRA, what is IGRA? This is interferon gamma release assay. This is a blood test. It detects the interferon gamma released by CD4 and CD8 T lymphocytes on stimulation with antigens of MTB complex. There are two IGRAs. One is quantiferon TB gold plus assay. Just because the name gold, it is not a gold standard. Then the second one is T-spot TB assay. The antigen used are very specific. Early secreted antigenic target 6, ESAT6, and culture filtrate protein CFP10. The antigens are not encoded in the genomes of Mycobacterium bovis. This is a BCG strain, and also in most species of NTM. So the expectation is IGRAs will be more specific than tuberculin skin test. And always both IGRAs are performed with a positive and negative control. Always they have two antigen tubes. TB1 has peptides from ESAT6 and CFP10. This is to elicit the response from CD4 T helper cells, whereas the test tube Q has peptides targeted for CMI response from their CD8 cytotoxic T lymphocyte. This is to improve the overall test sensitivity. Test is positive if it is more than 0.35 international units per ml. But you do have indeterminate tests. If you have indeterminate test, you need to repeat it. Whereas the T-spot TB assay, it is performed with peripheral blood mononuclear cells, which is incubated with peptides from ESAT6 and CFP10. What does it do? It finds the number of interferon gamma producing T cells. That means spot forming cells. It is always performed with a positive negative control. The number of spots, if it is equal to or more than 8, it is positive. If it is less than or equal to 4, it is negative. What is in between? Then if it is in between 5, 6 and 7, you need to have a retesting. And if you have an invalid test or indeterminate test, you are supposed to once again redo the test. So this is the latest paper which came out in December 1, 2021 from American Academy of Pediatrics for detecting TB infection. What is their quote? They said, 2 available imperfect methods are both tuberculin skin test and IGRAs, because they don't distinguish between TB infection and TB disease. They also tell that there is suboptimal performance in immunocompromised patients who have the greatest risk of progression to TB disease. So what is it? If there is going to be a discordant result, it is going to be difficult to determine if a negative test result is more specific or positive test result is more sensitive. All the more confusing. So what is the take? In terms of accuracy, neither quantiferon gold tube or T-spot TB is strongly preferred over other. You can do any one of these 2. But if you keep on repeating the test, you can have variability due to sample collection issue. And if you don't process it within 24 hours of collection of the blood. The agreement between the skin test and IGRA are very good in unvaccinated children rather than in vaccinated, BCG vaccinated children. If you have high DB burden population, or if you have suspicion of extrapulmonary TB, IGRAs are more specific. But if TST is positive, but IGRA is negative, whether to treat or not, it is based on the clinical judgment. You need to assess whether the risk of progression to disease and the degree of exposure. Based on these 2, whether to treat or not, you have to decide. So what is the take? The take-home message for this is the tuberculin skin test is preferred if the child is younger than 2 years. IGRA is preferred if the child is 2 years or older, or if they are not going to come back for reading as for tuberculin skin test. You need to do both TST and IGRA when the initial and repeat IGRA tests are indeterminate, or when any one of the tests, TST or IGRA result is negative, but if you still have clinical suspicion of TB. Now we come to CBNAAT. What is CBNAAT? Cartridge-based nucleic acid amplification. Why this came? Because WHO classified TB as bacteriologically confirmed and bacteriologically, not bacteriologically confirmed cases. That is a clinically diagnosed case. Bacteriologically confirmed means it can be smear microscopy, it can be culture, or with one of the WHO approved rapid diagnostic, that is the expert MTB. The expert MTB has got better sensitivity when you compare to smear microscopy in pulmonary TB in children, and also provide rapid confirmation. Within 2 hours, you are able to get the result. And the meta-analysis shows only with a positive culture means 100%. For sputum, it is 62%. For gastric aspirate, it is 66%. The negative expert result, that means it does not rule out tuberculosis. And expert does not detect MTB in most children with tuberculosis. So what is the next step? We have a second generation which came out in 2017. This is called as Ultra. What is it? 2 changes are there. Each cartridge has got larger chamber for DNA amplification, so that there is a larger volume of sample which goes into the actual PCR reaction. Also, 2 additional molecular targets for MTB has been introduced, so that even if the sample has about 16 bacilli per ml, it will be able to pick up a positivity. And the modifications are only with the cartridge, so you can use the old system itself for using the Ultra. We know that induced sputum and gastric aspirate are invasive procedure, and they require well-trained staff, good lab, and a good hospital setup, which may not be available in a low resource setting. And we know that children swallow sputum, MTB can pass through the GAT, you can detect the MTB in stool. There are several studies which says you can use expert system for doing the stool finding for tuberculosis. This is a study published in 2021 November in China, 141 children with presumptive tuberculosis. What they did in the gastric aspirate, they did the culture AFB and ultra. In the stool sample simultaneously, they did ultra and expert. What are the results? Culture is positive in only 22.7. If you add AFB, it increases to 24.8. If you had expert, it is 1/3, 34% is positive. And if you're going to add expert ultra, you have around 57% positivity. And if you add stool ultra, it leads on to 70% positivity out of 100 presumptive cases. So what does it indicate? In children, stools are alternative samples to gastric aspirate for ultra tests. Stool and gastric acid based ultra tests are appropriate for TB diagnosis. And what is the disadvantage? You have a high proportion of trace call-in positivity. And head-to-head studies with ultra, with stool sample and respiratory tract samples, they show similar results. You know that there is a higher frequency of invalid test results from stool samples when you compare to gastric aspirate. This may be because of the presence of PCR inhibitors in the stool sample or debris leading to clotting and errors in the test. And you need to have a standardized protocol for examining the stool sample in expert ultra. And coming to diagnostic algorithm. This is given in now December 2020 Indian Pediatrics by Dr. Varinder Singh et al. In a presumptive TB, do a chest X-ray. If the X-ray is normal, think of extrapulmonary TB. If the X-ray is highly suggestive, you do the NAT and go according to if it is going to be NAT positive. But if the X-ray shows non-specific finding, after antibiotics, repeat the NAT. If it is still not positive, you need to look for sites for taking other samples. But after doing that also, you are not able to pick up, you have no other alternative diagnosis, treat as clinically diagnosed probable TB. Why? Even this algorithm has got clinically diagnosed TB because many a times the microbiology may not help. So you can have underdiagnosis and overdiagnosis in TB. It is critical to change the commonly held misconception and dogma that diagnosis of TB in children is always difficult. A good history, clinical exam, and properly taken X-ray are basics while evaluating a child with presumptive TB. Always aim for microbiological diagnosis, but know there is limitations of bacteriological tests. You always have to keep that in mind. Clinical diagnosis is possible with reasonable accuracy, especially in resource-limited context. So avoid both overdiagnosis and underdiagnosis. Thank you. Thanks for the opportunity.
Thank you, Dr. Gowrisankar, for elaborate lecture on TB infection. I think there will be a lot of queries. Please write it and send it to the dais. You also said about recent tests and detect TB infection, and also WHO classification about tuberculosis and importance of history. Then now I invite Dr. Nalini, Professor Dr. Nalini.